Welcome to all the viewers to this weekly webcast of Indian Medical Association in association with eMedinexus and our partner Librate. In fact, we are doing a program every Thursday, but this Thursday, because Dr. K.K. Agarwal is not here, I'm the only person doing it. K.K. is down with fever, but we have a very eminent obstetrician and gynecologist, Dr. Punita Mahajan. She is the medical director at Dr. Baba Saheb Ambedkar Hospital in New Delhi. She is a graduate from Lady Hardinge Medical College, New Delhi, and a postgraduate from Safdarjung Hospital, and has been involved in various maternal health activities at central government, Delhi government, and other levels for the last 35 years. And the topic today we are going to take up is a very important topic of antenatal care. And you will appreciate that antenatal care is the most important part of a lady's health and her social system. And not only that, even for the fetus, even for the child to be born, it's a big thing. I think that period determines everything about both of them.
Yeah.
How the child is going to behave, how the child will have its health, how the parameters will be there. And similarly the mother, there are so many, we listen about maternal mortality and this and that.
Absolutely.
So I think this is a time, you being the custodian of the, maternal health in Delhi, you are the right person to answer our questions. So first is, we like to know that how will you, definitely talk about, somebody asks you what is the antenatal care and how do you start it. These are the few issues that every new wedded lady or a newly pregnant lady will ask you. And the family is concerned about it. Everybody is concerned that the first child or second child is being born in that family. So please, elaborate on this issue to all our viewers all over the country. How to start it and what is real antenatal care in Government of India guidelines.
Thank you, Dr. Monga. Basically antenatal care, or we can call it also as prenatal care, this is a systematic supervision of the pregnant woman, which includes examination and advice all throughout the pregnancy. So pregnancy is basically a physiological phenomenon, and for some it is actually very fearful event. So during this antenatal care, we have to allay the anxiety of the expectant mother, the family, especially when they are having this event for the first time in the family. So this is one very important part of the family, and the growth of the family, the future of the family, all depends on this. And the objective of giving a proper supervisory antenatal care is that at the end of the pregnancy, we are able to have a healthy mother with us, and we are able to have a healthy living baby, and preferably through a normal delivery route. So with this objective, we provide a systematic care to the mother. And other things, other advantage of giving antenatal care is that we are able to identify high risk cases. So those high risk cases need special attention, and if we are able to provide timely attention to these, we can prevent to a certain extent and identify certain complications which are associated with pregnancy, and then we can timely manage them. So ultimately we will be able to give a healthy mother and baby at the end of the pregnancy. And this period also, during antenatal period, we ask the family to plan the place of delivery, where they have to do, and we have to educate them about the physiological events which will happen during the pregnancy. And secondly, some antenatal exercises, some advice about the supplementation, everything is done during this antenatal period. And then this is a time when they are ready to listen to the contraceptive advice also. So because this is the period when they have to think. See, after the baby is born, the whole family is busy. And this is the period where we can give them advice about the contraception, so that there is gap in the next pregnancy, and it will definitely be able to improve the health of the mother who's just delivered, and she'll be able to give better care to the baby. So with all these objectives in mind, the antenatal care is very essential to be provided to these expectant mothers.
So there is always a question. Some people are nervous about it in the beginning, but what is the best time to start antenatal care? I mean, when should a pregnant lady go to her gynecologist or obstetrician for the first time, first visit or restriction, whatever you call it?
Absolutely. See, as soon as the pregnant mother in any woman in a reproductive age group misses her first period, and I think we have to rule out pregnancy. So best time to report is as soon as she misses a period, and ideally that will be early registration or first visit, and then mother has to go every month till she is about 28 weeks, and then fortnightly till she is around 36 weeks, and the whole pregnancy duration is around 40 weeks. So after 36 weeks till she delivers, she has to go weekly. This is an ideal schedule of the visits, but there are WHO recommendations, and in developing countries we recommend that minimum 4 visits are essential during the whole pregnancy if it's a low risk normal pregnancy. So first visit is in the first trimester. That means it should be completed before 16 weeks of pregnancy. The second visit is between 24 to 28 weeks. The third visit is around 32 to 36 weeks. Around 32 weeks, and the second one is around 36 to 37 weeks. So these are the
That
four.
is about rural settings.
This is in rural settings, any low resource settings. This is minimum 4 visits which we recommend. And the schedule which I have told you, normal ideal schedule, is the one which I talked earlier. And the visits may have to be increased if they are associated complications or any medical disorder. So depending on that, the visits can be rescheduled and they may be more frequent.
So that is the protocol of antenatal visits
Right,
in your
right,
setup
absolutely.
system. But then, I mean, what does a patient expect from you on each of these visits? For example, in the first trimester, second trimester, third trimester, what is the emphasis that you put on once the patient comes to you for?
Yeah. So see, if the patient reports to us for early registration in the first visit, see, we have to confirm her pregnancy. So that can be depending upon when she has arrived. Suppose she has arrived just after missing a period, then urine pregnancy test can be done to confirm her pregnancy. And once the pregnancy is confirmed, see, we have to give her a set of investigations which have to be done to get a baseline status of her health. And secondly, these investigations are essential for further management also. Like we will take a elaborate history first. We will note down her last menstrual period, which will help us in calculating the expected date of delivery. So after the expected date of delivery is defined, and we will take the detailed medical history, past history, anything significant which may have a bearing in this present pregnancy, that has to be noted. And if she has delivered earlier, the details of the previous delivery is very essential. See, what was the nature of the delivery, and was there any complication in the previous pregnancy? How was the baby? Was the baby healthy? Were there any anomalies in the baby? Did the baby breastfeed well? What was the weight of the baby? What was the route of the delivery? What was the postpartum period? So this detailed obstetric history is very essential, because this will have a bearing in the further management in this pregnancy. So this is about the history part. Then we will do an examination. Usually with the advent of ultrasound, the pervaginal examination is not required now. So after the examination history and everything is done, we advise certain investigations. So on the first visit, when the patient is coming, we give routine antenatal investigations like a hemogram for the patient, urine analysis, complete urine routine, as well as microscopy examination is essential. Then we get a blood group done for both ABO and RH. And in case she turns out to be RH negative, it's very essential to have the husband's blood group available with us. Because if husband is positive and the mother is negative, we have to be careful in the pregnancy. And if she has delivered already earlier, then we need to know the baby's blood group earlier also, and whether she had a history of transfusion done earlier in the past. What was the baby? Did the baby require any transfusion during the early phase of birth? Then after we have done these routine investigations, then we have to get nowadays Government of India guidelines are there that we have to rule out gestational diabetes mellitus in all patients.
So from the very beginning, from day one?
Yeah, so what we do is there is a protocol. In the first visit, we get one oral glucose challenge test. See, earlier there were a lot of tests done with 50 grams and 100 grams glucose and one step, two step. Now the guidelines are, DIPSI guidelines are that we are getting, with 100 gram of glucose, we are giving patient, in any, irrespective of her fasting status, we are doing the plasma glucose testing after 2 hours. So if the value is more than 150 milligram percent, we straight away label the patient and treat her on the lines of gestational diabetes mellitus. But if this investigation at that time is normal, we will repeat it again at 26 to 28 weeks of pregnancy, and then same protocol is followed. So this is basic outline.
What about HIV when you get
So I'm
it?
coming to that. So these are the basic investigations we get it done. As a routine, we are also, as a part of the basic investigations, are doing VDRL and HIV for these patients. See, coming to some people in, like we are working in a low resource settings. So our public hospitals are not providing free access to all advanced investigations, which may be ideally done in a pregnant mother. So in that we will include prenatal screening also. So prenatal screening means we are basically screening that the baby to be born is not affected by any congenital inherited defects. So for that, what we do is that in low resource setting, we identify the patients. Like if the mother is more than 35 years of age, or if she has given a birth already to a congenitally abnormal baby, or baby was born with birth defect, or if the family history is there that siblings or somebody in the family has given birth to babies with congenital defects. So in those high risk patients, we will resort to giving this prenatal screening. So this prenatal screening can be done in the first trimester. So in that case, we do serum examination. Mother's blood serum examination is done. So we measure 2 blood tests. One is we do beta SCG, and then we do PAP-A, which is pregnancy associated plasma proteins. And if values of these two is again along with ultrasound done at this stage for nuchal translucency. So combination of these two, the blood test as well as this ultrasound screening, or NT screen it is called. So if we combine these two, then anomalies like Down syndrome, that is trisomy 21, it detects to almost 90% with a false positive rate of only 5%. So basically this blood test will give us that there is a high risk of Down syndrome. And if we combine it with this NT ultrasonography, this will give us a higher rate of detection. And this ultrasound at this stage will also tell us, one is that whether there are, sometimes multiple pregnancies are there. So that they will tell us the viability of the pregnancy can be, ascertained from this scan. And also gestational age. See, this is very, because these tests also depend upon the correlation with the gestational age. So this is first, this is the antenatal prenatal screening done in the first trimester. But if the risk is confirmed, then you have to confirm and do a diagnostic test. So that is done later on, either with coronary villus sampling or amniocentesis. So this can be done under the care of a geneticist also, or gynecologists themselves can get these tests ordered, and in case of doubt or any opinion, they can consult the genetist. So this screening is not routinely done in all public health organizations in all patients, but yes, when it is indicated, we do it. And if the patient can afford, I think in ideal circumstances, especially people coming to the private setups, these tests should be done. Then thyroid screening. Similarly for thyroid, TSH levels have to be done. And this is not a guideline mandatory for all, but wherever there is a history, high risk case, or patient is already on diagnosed case of hypothyroidism, then we have to get the TSH done also in these patients. So these are the basic investigations which we'll do. And in case the hemogram shows that MCV is more than 27 picogram, and we feel that there is a high risk factor, then we have to screen for thalassemia also. So that thalassemia, in case the suspicion is there and screening tests have been done, it has to be confirmed by HPLC examination. So these are the tests which we do on the first visit. And in case patient is already having some medical ailment or anything, so then the test according to the need would be done for
Sure.
those.
That's right. And and any immunization during this period? No, is not required.
See, in first trimester, if we feel that the patient is coming from a setup that she's not going to probably report, like especially in a rural health setup, we feel that the patient has come here, but we are not sure whether she's going to come. We may give her a first dose of tetanus toxoid, the immunization which is required. Otherwise, we prefer to delay it for a little later. And
Okay.
yeah.
And second trimester?
Yeah, so I was saying that let me just complete about the immunization.
Sure.
See, basically, in a pregnant expectant mother, we give 2 doses of tetanus toxoid to give her a cover for tetanus, because this has a, if unprotected may, land up with tetanus in a neonate also, which is, not a very pleasant thing to happen. So the difference between the 2 doses should be at least minimum 6 to 8 weeks. And we should plan in such a manner that the second dose is at least 6 weeks before the expected date of delivery. Because see, sometimes patients are not coming regularly for antenatal checkup and they tend to miss, and especially this happens in the rural settings. So then in that case we have to ensure that the second dose is completed before 6 weeks of expected date. And now in the private setup, and I think the vaccine, immunization of this Tdap has come, which in this the second dose can be replaced by Tdap, where the element of pertussis, which is in this vaccine, this will give a protection to the newborn for pertussis. So in private settings, they have already started replacing the second dose with this. So, and in case patient comes in a subsequent pregnancies and she's sure she has received the full dose of immunization, then we give only 1 dose of tetanus toxoid to the mother. So this completes the immunization schedule during the pregnancy. So now I just wanted to also say that suppose the patient has not come for a first trimester screen, she has somehow come late. This first trimester screen is usually, the prenatal screening is done between 11 to 13 weeks of pregnancy. So NT scan is also done around 12 to 13 weeks, and these blood tests are also done. Suppose patient reports late to us. So in addition to whatever investigations I had said that they are required in first trimester, we can do second trimester screening. In this second trimester screening, again, we have a double marker, triple marker, quadruple marker. So what we do is that we get these tests done. So one is beta HCG we get done, then estriol we get it done, and then maternal serum alpha fetoproteins, and this beta HCG. So these markers are done, and in a quadruple we add also inhibin A. So basically these investigations again will tell us whether there is a higher risk of Down syndrome in the baby expected. So this will be again confirmed by diagnostic tests. So diagnostic tests, I said earlier, in case patient reports early, we get a chorionic villus sampling done, or if patient comes late, we can get amniocentesis done. So this usually in a public health setting, as I said earlier, we leave it only for patients who are high risk, and we get these
Not
done.
in the routine.
Yeah, not in the routine. Then this is again augmented by a anomaly scan. This anomaly scan ultrasonography is done usually between 16 to say 18 to 20 weeks. So this detects many bony abnormalities like spina bifida and encephaly. See, these can be diagnosed by this structural scan, and combination of this structural scan and the second trimester staining will give you a very good result for detecting these anomalies.
Okay.
So this
This level 2 scanning,
yeah.
you get it done in every patient that comes to your hospital?
Yeah. This even in public health facilities, we
yeah.
try to get this done. We have to get it done because it has so much burden, mental burden on the family if the baby is born with anomalies, and it's like mentally also if mother gets affected quite a lot. So it's better to diagnose early as possible these things, and accordingly a decision can be taken whether the patient the pregnancy has to be continued, or the family is prepared that these defects are there, so they have to deliver at a place where after delivery, with minor defects, the baby can be handled and some surgery can be
And
done.
if needs to be aborted, that can be done.
Yeah, that's what I
That's the
said.
period,
So
yeah.
decision for major anomalies can be taken timely, because at present we have a limit to terminate pregnancy only up to 20 weeks.
Yeah.
So only the structural scan, if done much earlier and a decision is taken, we can give this option of a second trimester NTP in view of anomaly which is not viable. The baby
So
is
beyond
not-
first trimester, you mean that there are only scans to be done, not
So,
many
yeah,
more investigations. We don't
Yeah,
require
so
any.
basic once we have done the
Yeah.
basic investigations, depending upon the result, if further evaluation has to be done for any particular investigations, we do that. And secondly, in case she's having any morbid medical condition or some other, then specific investigations can be ordered. Otherwise, for a normal low risk pregnancy, these are the set of investigations which are done. But every time patient is coming for a visit, so we have to, and baseline, in the examination, we have to record her weight, her blood pressure, that's compulsory. And in fact, on any antenatal visit when she is coming, this is basic minimum record which we have to maintain, because this will help us diagnose hypertensive disease disorder in the pregnancy, and it can lead to many complications, and the complications may be to a grave extent of patient landing up. I've seen patients coming with high BP, they've not gone for antenatal checkup, BP has not been recorded, and patient lands up simply by throwing up it, and she comes as
That's right.
eclampsia. And in eclampsia there is a high mortality rate. So in today's time, I think there is no patient should be coming with eclampsia to any of the health facilities. So we must record blood pressure, weight at every sitting, and also urine albumin sugar. This is also done at every antenatal visit. And hemoglobin has to be done at least 3 times in the pregnancy if it is normal. Of course, if it is less, then we have to go for peripheral smear and try to detect what is the cause of low hemoglobin and all. So when I'm talking about normal, at least minimum 3 hemoglobin levels have to be done in the antenatal period.
Any more vaccinations before delivery? Beyond you talked about tetanus.
See, normally we give tetanus, but if the patient is, staying in a place, or there is an endemic influenza there, so influenza vaccine can be given. It is not contraindicated. It can be given if, in case there is an endemic influenza during that period which is there. So these are the vaccination which we normally recommend, and we ensure we started with the antenatal period, but we must ensure before the mother, the patient plans the pregnancy, that she is vaccinated against rubella. So that rubella vaccine is not given in the pregnancy at all. We presume that patient has, from the history initially, and if we have an opportunity, that patient comes to us for, preconceptual counseling. Sometimes before the conception, patient comes to us. Nowadays the awareness is increasing, and sometimes the couple wants to plan a pregnancy, they consult their doctor. So that time we should ensure that patient is protected against rubella. Because and if there is any doubt, or patient has had an exposure where we feel that it may be a fever with rash and it may be rubella, then pregnancy is to be avoided for almost 3 months. And in case patient doesn't give any history of rubella vaccine having taken earlier, and we vaccinate the mother in pre-conceptional period, then we tell them definitely to avoid pregnancy for 3 months minimum. And since I'm talking about preconceptional counseling, I would like to just add one or more things. When couple is planning pregnancy, we ask them to start taking the lady has to start taking folic acid. So at least 6 weeks before patient is planning a pregnancy, and by simple one oral tablet of folic acid, the incidence of neural tube defects are much less seen to be there. So it is a simple thing which we can do. We are having adolescent clinics in various hospitals, and sometimes the lady is coming for some other gynecological problem, and when we take the history, and if we feel that she is and these women are in the reproductive age group and they feel that she may be planning a pregnancy, at least this kind of advice can be given to the mother, to the lady, not yet a mother, so to the lady. So, and we can also tell them that about contraception there only. If she's just got recently married, we can tell her that she can avoid pregnancy for another 1 year or so till she gets adjusted. Then the anxiety and the fear which they have about pregnancy, that can be allayed during the pre-pregnancy period. And we can, if she's heavyweight and she's obese, we can tell her to reduce weight at this stage. And if obese and heavyweight do add to the pregnancy complications later on. So that's these kind of advices can be given in the, and I think now a lot of young couples do seek advice before conception. So and in case she's having any medical ailments like a heart disease or she's having diabetes earlier, so at least we can ensure that by the time she is getting pregnant, her medical condition is well under control. So that will reduce anyway complications later on. So we covered about preconceptional advice. In the first trimester we have covered the basic investigations which are done, examination which needs to be done. We talked about the follow-up also.
Now, once the patient comes to you, and do you advise her that what are the danger signs? I mean, she should consult you again in an emergency, or she should go to the hospital. What are these conditions in all these 3 trimesters?
Absolutely. I mean, I think that's very essential. We should all emphasize certain signs and symptoms we must tell the patient also. Yes. See, any time patient during pregnancy is having bleeding by vagina, that's one sign she should immediately report to the, irrespective of gestational period. See, in early pregnancy, it may be a simple indication that she's going in for threatened abortion, or she's already having a missed abortion or going into the process of abortion. So anytime there is history of bleeding baby, she must report. Later in pregnancy, it may be an indication of antepartum hemorrhage or placenta previa. So these are the medical conditions which may give you a signal in the beginning that if the patient gives history of bleeding PV or threatened preterm labor, so we must take care of that. So patients having severe, in the early pregnancy, she's having excessive vomiting. So that excessive vomiting anyway has to be taken care of. She may go into dehydration. Secondly, there are certain medical, certain complications of pregnancy which may be associated with excessive vomiting. So we must look and inquire that is she having multiple pregnancy? Is she having hereditary mode? So this simple, sign of excessive vomiting can lead a practitioner to look for some other complications of pregnancy. So if she's having fever, high fever is again detrimental to the fetus inside. If she's having severe headache, epigastric pain, and blurring of vision, see these, and pain abdomen, see these are the danger signs which she's having excessive urination, so or burning micturition. So these are the signs which will directly affect the fetus. So with these danger signs, she's having excessive swelling in feet, she's having pallor, she's having breathlessness, and she's on simple routine household work, she's getting breathless, and she's not able to do it. So you must investigate, is she having cardiac problem, is she having anemia, which needs to be treated. So these are danger signs and symptoms which the pregnant mother must be told, and she should report to the attending obstetrician immediately.
How about those fussy ladies who come to you, decreased movements and every time they are very
right. So usually, once
counseling.
Counseling has to be done, and then of course, other than counseling, I think first I have to ensure that yes, this is actually a fuss she's making and she's not having decreased feeling movements. So in the early pregnancy, we have to counsel her. But towards the 3rd trimester, after 32-34 weeks of pregnancy, in fact, this is one advice we should give to her, that she should count her fetal movements. So that's called KIP count or daily fetal movement count. So that we should do and tell her that during 10 to 12 hours during the day, she should count, and minimum 10 fetal movements she should have. So if she is having this 10 fetal movement count daily, is a very good sign of well-being of the baby. So if she can't count for 12 hours, another thing is that 1 hour post meal, anytime she should have at least minimum 3 movements in an hour. So these kind of small things, if we spend little time with the patient and tell them, I think this will give them not only confidence, baby is doing all right, and as you said, that it will engage those, women who are little more particular about their. So this is one thing.
But in
which,
government setup, I mean, how much time are you able to devote? You have to talk about nutrition, you have to talk about the general examination, you have to talk about counseling about fetal movement, all these things. I think you people are so worked up and the short of time that it must be very difficult for you to adjust every patient there in that period.
Yeah, but we manage. And I think whatever we have just now talked, this is bare minimum essential which we have to, the information and supervision we have to give. So it works in a team manner. See, we have a separate set of nurses who are taking the weight, blood pressure, getting the investigations done, patient, and the person who is giving immunization, she probably can do little more counseling to the mother. And she's also telling them some antenatal exercises also. So in our hospitals, I have clubbed this, giving information about the exercises with the person who's giving tetanus toxoid to the. So probably she can have.
So you
spend
talk
little
about
more
the
time.
exercise. I think our GPs, I mean, all over the country should know what type of basic exercises can be started at what time in the antenatal period.
Yeah, so there is proper schedule of exercises. See, we don't want to give very too vigorous exercises.
That's right.
Simple walking, and walking right till the end of her pregnancy is always advocated. So talking about the advice, exercise is a very good part of it. Now we have special yoga for pregnancies. Yogic exercises are also there in pregnancy which are safe. Otherwise, simple stretching exercises, breathing exercises. So these kind of exercises can be, told to her once right in front of you, and then she can gradually practice them at home. So this will help her give her relaxation. See, some muscle stretching, and the ligaments get stretched, and it results in a lot of pain in the lower abdomen. So if she is doing this continuous stretching exercise, simple leg raising exercise, and these exercises she does, it will help her later at the time of delivery.
And now we talked about the basics of everything. So, in spite of all this, you people are doing a lot. Institutional deliveries in cities are, I think, pretty good, 80-90% in some parts of the country. And in other parts, maybe around 30-40-50% also.
Right.
But India is ranked very poor in maternal mortality.
Absolutely.
And all over the world, people are talking about Indian maternal mortality ratio. So, what advice you can tell to our GPs especially? Gynecologists, if a patient goes to them, it's okay. But a GP is the first point of contact, even in a pregnant lady, for example, in some part of the country. There may not be a qualified gynecologist nearby. So, what a GP should know about this, that number one, he has to partner in getting the lady delivered in a hospital.
Correct.
Then he has to see to it that minimum maternal mortality occurs. What are the basic symptoms and signs he should look for, and advise his patients or the family, for that matter, in a remote setup. That is more important.
Yeah. So very well said. I think this maternal mortality is definitely an issue with us, and we've got a long way to go. See, we are still in Delhi better placed. We have a mortality of around 104, the last reported one for 2016 per 100,000 women. But our country's overall mortality is still high, and we have still states where they are much higher also. But we have states like Kerala where it is much less also. So basically, I think you very rightly said that GP and other people who are involved with giving primary care to the patient should be sensitized. See, one thing is that whatever basic we talked about, other than the prenatal screening, these are simple tests which can be done, simple history taking which can be done. Basically, my request and appeal to the practitioner is that they should learn when to refer the patient to a setup where she should be under care. See, if her blood pressure is coming high, okay, if she's having anemia, see, this is a time to refer her in the antenatal period itself. See, if you send her with a 6 gram, 7 gram hemoglobin at the time when she's about to deliver, we probably already lost 9 months where we could have built her up. Because see, the hemorrhage is a direct cause of maternal mortality. It amounts to almost say 25% of the maternal deaths. And if a mother is already anemic and has hemorrhage, see, indirect cause of maternal mortality, anemia, tops again 25%. I mean, very high, almost 20-25%. So the combination is going to be detrimental to her. So my appeal to my friends is that they should timely refer the patient. In case anemia is not getting corrected by simple medication and investigations, they must refer her to a higher center. If her blood pressure is coming high, not getting controlled.
What is high blood pressure in pregnancy?
See, in pregnancy, if any time the blood pressure is 140/90 on 2 occasions, 4 hours apart. See, that means we must investigate her further for hypertensive disorders. And she has to be in continuous care. So once that continuous care can be provided at the setup, it's okay. But otherwise, we must refer her, get her basic investigations done, and then the treatment can be done by the GP herself for rest 2-3 months, and then they should know that in case she's having headache, a mother who's on 140/90 BP, is persistently having headache, is started having epigastric pain, is started having blurring of vision, as I said, those danger signs, then that's the time when she should refer them to the higher center.
And what is the expected blood pressure? You talked about the high blood pressure. Optimizing a blood pressure at that level, 120/80 or?
Yeah, so we 130/80 also we do.
Even 130/80.
Right? So anytime it touches the lower limit of 140/90, we have to be vigilant.
Okay. That's
And
it.
then we have to get
What
further
other causes of
investigations done.
maternal mortality, PBH or whatever?
Yeah, unfortunately, sepsis also ranks
Sepsis,
almost
yeah.
second high in the list of causes for maternal mortality. So, from the sepsis, you can imagine that probably we are still not yet, competent to give proper care to the mother during delivery. So she can have infection in the antenatal period, which has not been taken care of, or at the time of delivery, some sepsis has occurred. Then septic abortions. So in spite of so much awareness, in spite of giving facilities, the government is doing quite a lot of IAC, but we are still having a lot of septic abortions with us. Then hemorrhage I've already talked about, obstructed labor. See, we shouldn't have mothers having obstructed labor. So we stopped at around 28 weeks. We can talk about it a little more. See, when the mother is in the 3rd trimester, see, that time we have to be a little more cautious. In case the pregnancy is absolutely normal, low risk, there is no other indication, then simple examination and medication which the patient is taking is good enough. And when she has crossed 32 weeks of pregnancy, we talked about fetal movement count, we do that. And then if she is first pregnancy, primary gravida, then we must do a pelvic assessment around 37 completed weeks. So that will give us a rough idea whether her pelvis is adequate enough for the baby to pass through. In case it's if there is doubt about the parturient canal to let the baby pass, then we have to be very vigilant at that time. She shouldn't land up in obstructed labor. And especially in a rural setting, and as you said, if the patient are there at a place where they don't have access to delivery, these things should be planned, and micro planning should be done earlier, and they should be told to go to a district hospital where there is facility for cesarean also.
But most of the people in every setup, I think, especially the mother-in-laws or the mothers, they are always after your life that it should be a normal delivery.
Yeah,
how much risk and up to what extent you are ready to take it?
See, there is a lot of pressure.
Medical legal
Everybody
issues
wants.
also there.
Yes, I fully agree with you. And in fact, as an obstetrician, I would always like that I should give a fair trial and give her a normal delivery. But yes, we have to counsel. See, if we are sure that the patient, cannot be delivered normally, I think timely we should tell the relatives and the patient and take consent, proper written consent has to be taken.
Prepare them for that.
Prepare them, counsel them. See, in case it is a fetal, it is a non-recurrent indication, it's a fetal distress or something, we have to counsel them, and they do agree. It's just matter of counseling.
But I've seen ladies
Yes.
going from one hospital to another one, another to third one.
Yeah, if it is an elective cesarean, you have said for some reason, then they have a time to hop from one place to another. But if they are already in active labor, I think the counseling will help a lot in making them take a decision.
Okay, good one. And sometimes people will be calling you up, बुखार हो गया जी, कौन सी गोली खा सकते हैं, कौन सी नहीं खा सकते, एंटीबायोटिक ले सकते हैं कि नहीं ले सकते. Similarly, I mean, for various other ailments, they'll ask you about thyroid, they'll ask you about what hypertension medicine, they'll ask you about diabetes, anti-diabetics, what are to be taken, what painkillers are to be taken. Generally, I mean, what you advise your patients, or what I think a GP should know, what medicines can be given and what not to be done during that 9-month period.
Yeah, I think it's a very important issue you have raised. See, first trimester pregnancy, normally we avoid giving any medication. But in case, as you very rightly said, if she's having fever is also not good to have. Then we have drugs which are labeled as category A drugs. That means they are safe in pregnancy. Paracetamol, antibiotics like amoxicillin, ampicillin. Acidity is a big problem, and pantozole. So these medicines are absolutely safe to give in first trimester. One thing, as I said, they should be avoided, not for a small flimsy reason we are taking. But yes, if they are essential, these drugs are called category A drugs and they are safe to be given in pregnancy. But there are certain drugs which have got teratogenic effects, birth defects. They are not to be given at all in first trimester. See, they are labeled as category X drugs, which are absolutely contraindicated, like finasteride, danazole, and warfarin. Sometimes patients are having complications and recurrent abortions, or for some thrombophilic ailments, they are on some anticoagulants. So these drugs have to be stopped immediately. They don't have to be given. And there are, of course, drugs which are category C and D drugs, which can be given if the benefit of the drug is more than the harm it causes. See, so then that we have to decide. So we talked about drugs which are contraindicated. Safe drugs are these. After first trimester, when the organogenesis is complete, then we can give these drugs with caution category C and D. See, other antibiotics which can be given, we can give those. There is no
Second and third
trimester we can give.
Not much of a
category C and D drugs which don't have any teratogenic effect, those we should not give. See, drugs like sometimes tetracycline and all are being given, doxycycline, they're given for PID, patients having infection with taking earlier, they have teratogenic effects. We should not be giving those drugs. Metrogyl we avoid in first trimester, but in case she needs it, we can give it in the second, third trimester. See, that first trimester is the period where organogenesis is occurring. There we avoid giving these drugs.
And what about nutrition advice to the patient?
Yeah.
First trimester, second, third, whatever.
Right. We till now didn't talk about the advice. See, it is very essential that mother should be healthy at the end of the pregnancy. So her requirement increases because of the growing baby inside. So she has to be very careful about her diet. So minimum around 300 kilocalories per day diet is extra to be given.
Yeah.
So this has to be given in the form of carbohydrates, proteins, and everything. So in addition, so the seasonal foods which are rich in these proteins and all, they can be given. Those who can afford, they can have protein supplements along with the food. And other than that, medication. The medication is essential. So in Government of India has a guideline which is saying that we should give, in case iron is another one thing which is required to be given. So the iron is something which is required to treat her anemia. So that has to be given cautiously. We should start timely, and there are proper recommendations and guidelines that we should give 100 tablets of ferrous sulfate for 100 days. So this is for prophylactic use. That means she is not anemic baseline, but this is a supplementation which is to be given because of the growing need of her. But in case we realize that her hemoglobin itself is less than 11 gram percent, which is a normal hemoglobin which take, so then we have to give her a therapeutic dose of iron. So then we have to give her 2 tablets, 3 tablets depending upon her hemoglobin level. So in the advice in the nutrition, not only the dietary supplements, but medication like iron and calcium. Calcium is another for growing bones we need it for her mother also as well as for the fetus. So we have to supplement calcium tablets also. So calcium supplementation usually starts in the second trimester. So now we have calcium which are along with the vitamin D, its combinations are coming. So they can be given to the mother. They will take care of her bones. So like if she is anemic, we can supplement vitamin C along with the, it increases the absorption of iron. So iron and calcium supplementation along with vitamin D is very essential for her to take care of her growing need. And diet, as I said, we have to supplement these. So in addition to dietary advice, she needs to do exercises, we talked about it. She needs to take rest. So 8 hours rest at night is very essential for a expectant mother. And if possible, and if the today's lifestyle permits, so we should recommend around 2 hours rest during the daytime. And then she should wear clothing which is suitable to the environment and the season. Loose clothing should be there. And then she should avoid the jerky movements, especially more so journeys which are long, and especially in the first trimester and the last. So these are 2 periods which are risky periods where these kind of journeys should be avoided. And in fact, some of the airlines do not allow the mothers to travel after 36 weeks of pregnancy because of the risk of delivering airlines. So that kind of is.
Ma'am, you have been in government service all through,
Right.
and involved in various government programs also. So what are the government programs for good antenatal care, more institutional deliveries, and taking care of the mother and the child? Primary health centers are there everywhere, but I don't know how much they work. But at least the government has found some guidelines, and they expect that they should be strictly adhered also. So what are these issues so that our people know what are the guidelines and what is expected of them?
Yeah. See, we have, government is definitely, reducing the maternal mortality and infant mortality is one biggest challenge which we are facing nowadays. And government is coming with a lot of schemes. See, we have a Janani Suraksha Yojana. So from the name itself, we can say that, this scheme is there where we are trying to give, promote institutional deliveries, and we are clubbing it with some incentive. So it is a safe motherhood program which is being clubbed with a monetary incentive. So those mothers who are delivering in the hospitals, they are being given monetary incentive. Rupees 600 is being given to those mothers who are belonging to BPI category or those who are belonging to reserve categories. So without any other criteria, all these mothers are being given this benefit. So and we have ASHA workers who are a link between the Government of India and the society. So these ASHA workers are bringing the mothers, encouraging them to deliver in the institutes. And in fact, we are through another scheme, Janani Shishu Suraksha Karyakram. See, here we are promoting that the institutional deliveries when the mother is having, she does not have to go through any out-of-pocket expenses. See, we are providing all facilities to the mother free of cost. The government is paying for it. Mother doesn't have to say, starting with drugs, starting with investigations, any blood which is required, diet in the hospitals, all is provided free to the patient. In fact, we are even providing transportation free from home to the hospital and hospital to home. Through this scheme, that also is free. The CAT 102 number, is can be dialed, and ambulance will be there at the doorstep of the mother to bring her to the hospital. So these kind of attempts
How
are.
practical it is?
No, we are. I'm telling
Because
you.
I have been outside in government, and
Yes.
in those maternity homes where there was an ambulance, there was no driver. And
No, see,
in
we
other, now
down
you
here-
talk about 102,
Yeah.
it's okay. I'm talking 5 years back.
Yes.
And when there was a driver, there was no ambulance in that unit. So it has always.
Very rightly said, and we try to improve. See, we are trying to improve the quality in the government hospitals, and quality is a journey. We were not good at quality earlier. We are trying to improve. And this CATS ambulance, have recently, you must have read that they have further strengthened the set of these CAT ambulances. So these ambulances are ferrying patients, and some of the patients are taking definitely advantage of this number, and they are using those ambulances even in my hospital, while more so for going home. See, from coming home, sometimes in Juggi Jhompris, the drivers were facing problem. So they try to, through now everybody is having mobile. Through the mobile, they do connect, and they reach at a place where the ambulance can pick them up. So these services are being utilized, and we are actually passing more messages, and more of these services can be utilized. So in fact, we promote admission for normal deliveries till 48 hours of delivery. So diet and everything is being provided free to the mothers up till 6 weeks of post delivery. That means 42 weeks. We are providing everything free to the mother. If she has to come for readmission, any investigations are to be done. She lands up in some complications. She needs some help. The government will provide medication free of cost. And for neonates also, this earlier it was till 1 month. Now we have extended this to 1 year. So all the neonates will be provided free of cost treatment, drugs, everything.
Immunization.
Immunization, everything free in these setups. As it is, our government has taken a initiative of 100% availability of medicines. But before this initiative was taken, we had through Jani Suraksha Yojana and this JSSK scheme, we were providing these kind of incentives to the.
But in spite of all this, you would agree that there is a lot to be done, especially in remote area.
Yes.
Even in a private PHC or a small maternity home in the periphery, any complication, the patient has to be rushed, and then there is no ambulance, there is no anesthetist available, no pediatrician available in most of these places. So I mean, still, the government is framing guidelines, I know.
Yeah.
But they still have to reach. In Delhi, it would be okay.
Right,
But they have to
well
reach
said.
the periphery. That is the most important challenge for the nation.
Right.
For the whole health structure of the country. It has to be built up in a way that the remote test area, people get all the benefits. They don't have to run around. We come up with a set of systems where a primary health center or a primary maternity home, has part-time anesthetist or a call-in anesthetist or a pediatrician whenever there is a delivery, and they don't have the facilities for cesarean section also at most of these places. In these cases, they have to sometimes transfer a patient to 20-25 kilometers also. All these issues still, I think, they need to be worked out.
Definitely, they are challenging issues, and may I just tell you that we are working towards these also. Some of the peripheral hospitals where the doctors are not available in the government setup, there is a move to move on to the private partner PPP mode. So we are inviting the private practitioners to join hands with the government setup, and some kind of working model will be definitely shortly rolled out, where the private practitioners who are available in that local area, they can use the facilities of the government hospital, and we can provide services to the pregnant mothers. And secondly, there is another Pradhan Mantri, what is it called? It's just been launched, Surakshit Matru Abhiyan. So this is a scheme which has just been recently launched, in which all those patients who have been missed out for their antenatal visit appointment in second and third trimesters, they will be line listed by the peripheral medical workers who are going to the field, and they will bring them, and we have fixed a date 9th of each month to bring those mothers for antenatal visit by the gynecologist or the medical officer, and this is one initiative which will help us in motivating those mothers who miss their visits. And my appeal to the private practitioners are that they can in fact fix 9th as the day where they are providing free antenatal care to those mothers during that day. So I think, I'm sure if we join hands,
Yes, it is.
Together.
Indian Medical Association has always already
Yeah.
given the call for the last 3 months.
yeah,
That 9th of most of the doctors,
yeah,
they are doing service
right, some
to
of
the
them
community like
definitely
this.
done.
And they are not charging or they are doing some free tests, etc. on every 9th of the month. It's a good call, I
Yeah.
believe. And,
So, and I think if we all join together, we will definitely get through this challenge, and we will reduce our maternal mortality and come up to a level of some of the developing countries,
that's nice.
developed countries.
So friends, you just heard Dr. Punita Mahajan saying everything about antenatal care and the government policies. I still believe that there is a lot to be done, and people like Punita Mahajan at the helm of affairs in the city of Delhi and in conversation with central government, these type of people should be able to be a link between the doctors and the government, and we should be definitely better equipped in a decade or so.
Definitely.
I think things are getting better day by day. So with these words, we thank Dr. Punita Mahajan for your time here, and we thank you all, and we'll meet again next Thursday at the same time. Thank you very much.